All right, so today I'm going live with Renata Nehme, who is a myofunctional therapist, and we will be talking about, of course, head, neck, and jaw pain, but how the tongue and mouth and airway can be contributing. And so we're going to have a really good conversation about that. I'm inviting her to the live right now, and here she is.
Hello, hello.
Hey, how's it going?
I'm doing great. How are you? Thank you for having me.
Yeah, thank you for joining on Halloween.
Yes, special
Uh,
day.
yeah, quite a day. Today we're talking about head, neck, and jaw pain. You, as a myofunctional therapist, you deal with the tongue, with the airway, with the mouth, and I really want to dive into with you, how this can contribute to all of these different things: headaches, dizziness, potential, like anything that you find there's a relationship for. And I think the people watching are going to have headaches, dizziness, jaw pain, neck pain, shoulder pain, and they're just going to feel tight, kind of brain fog.
Mm-hmm.
How can these things contribute? So, if you just want to kind of start off with just who you are and kind of what you do to kick it off that way.
Sure. My name is Renata Nehme. I was a dental hygienist. I was trained as a dental hygienist, and then my functional therapy just fell in my lap. And God knew that that was my calling. I fell in love with it, and now I no longer practice hygiene clinically. I only do myo online, and
Okay.
yes, online works.
Yeah.
We have patients in over 30 countries, and then I also founded Airway Circle that is more for professionals. Somebody said it's not working. Is it working, you guys? Please let me know if you can hear me. Um, and then I started Airway Circle, which is an online platform for healthcare professionals to learn more. Multidisciplinary wise, we have an online study club, and also for patients to find the right professionals. So we have a directory that is free for professionals to join and for patients to look for somebody.
Okay, great. So what have you found? Let's start very high level.
Okay,
What are the most common airway or tongue
I
tie
guess.
or myo related issues that you find people suffering from? Like what are the big dysfunctions going on in there?
It's such a mixture, and people are so complex. It is so important for us to kind of like step out of our box and what we were trained to look. For example, dentists look at teeth.
Hmm.
It's so important for us to step out of that box because people are so complex, especially when it comes to pain. If you go to all these different professionals, they're all going to think that they hold the key. But the truth is that we can better treat our patients when we work together. Many,
Yes,
many
absolutely.
people many people come to me first because they think that now they may have a tongue tie because
Hmm.
social media is out there and we're talking about these things way more. So all of a sudden they go, hold on, I may have those symptoms. Is there something that you can do to help me? um, so most people don't know they're tongue tied, and I think that that's where they start more than anything else, and then we find out that there's so many other things that need to be done.
Yeah, yeah, absolutely. Yeah, okay. So it's just they kind of find you by understanding their symptoms. So what would you say? And again, we can kind of dive into it together, but what types of things can people be experiencing? Maybe that's a better place to start. What
Mm-hmm.
types of symptoms might someone be experiencing? Actually, let me go back one more time. I think that this will be better. So, what are the problems that go on in the mouth? So, I know like you could have a restricted frenulum, you could have cheek ties, you could have lip ties, maybe you could have poor movement, collapsed airway. Like, what would you say are some bulleted um, issues or findings within the mouth that are not normal?
Yeah, so it's going to depend on what age you are and what phase
Hmm.
of development you are. So, on a baby, this baby might have problems latching, problems breastfeeding, problems bottle feeding, not
Hmm.
gaining enough weight, hiccuping a lot. So, usually, colic, all these issues that
Hmm.
my kids all had. Now you start getting a little bit older. So we're talking about the muscles of the face and what are the functions of the muscles of the face. There's so many functions. That's why
Yeah.
they're slightly different throughout each age of life. So
Hmm.
that's what we
Okay.
see during babies. Whenever they start getting older, what are you supposed to start doing? You're supposed to start crawling and walking and eating.
Hmm.
So if there's any dysfunction in crawling, I thought it was the cutest thing when my both of my children crawled with one knee only. That is a
Hmm.
muscle dysfunction. And
Yeah.
yes, it could be related to other things orofacially. And then after that, when they start eating, so are they choking easily on the food? Gagging is normal, choking is not. Are they having issues with textures? Do they not like certain things? Do they not chew their food? Do they swallow everything whole? Ear tubes. Usually,
Mm,
kids that have ear infection after ear infection could have a relationship to the way that their tongue is swallowing. So
mm,
whenever we're babies, we swallow with this infantile swallowing where the tongue goes back and forth. You may
mm,
notice when you first introduce food to a baby and you see the baby do this. And, I
mm,
remember going, oh my gosh, she doesn't like the food. Ha ha, ha, it's funny. No, that's just how they swallow. That means they're not ready to start solids yet.
mm,
After they start swallowing properly, the tongue is supposed to do this peristaltic movement. There's so much importance of this peristaltic movement. It's when it's going to initiate digestion. It signals the brain to tell the rest of the body, listen, get ready because there's food coming. There's something going on. Also, the vacuum seal that the tongue produces on the roof of the mouth empties the eustachian tubes. So if they're swallowing properly, they usually don't have fluids in the ears. But if they keep swallowing this way, either because they have low tone or because they have a tongue tie, there could be many different issues. But if they keep swallowing this way, then you see more of the
mm,
symptoms stay there. So in different phases of life, you're going to have different symptoms and you may need different professionals. It's not
mm-hmm.
always myofunctional therapy that's
Yeah.
going to be able to help with all of these issues. Then whenever the kids are older, constipation is related to this because usually these kids that have a tongue tie, they can't chew their food properly because the tongue is not going side to side. They swallow too early.
Mm.
If they're snoring, the roof of the mouth is numb, so you swallow earlier than you're supposed to. So the same issues. Um, Snoring, mouth
Mm-hmm.
breathing, those are all things that we're looking for.
So, and it's interesting. As they turn into adults, I see, teenagers and then just adults of all ages, and you start seeing things like just not necessarily that there could be a TMJ dysfunction where the joint's having clicking, popping,
Mm-hmm.
degeneration, pain, but even more often than that, it's I just feel tension through there. No, it's not just right here. It's just tension when I open, when I chew. It's kind of hard to do. You notice that they have neck pain because to open the mouth all the way, sometimes they start like tilting their head back and using other strategies to generate
Mm-hmm.
power because they're searching for ways to be able to because the floor of your mouth needs tension in order for the tongue to work properly. And in order for that to have tension, you need some of the muscles down here, the infrahyoids, to stabilize the hyoid bone so the floor of the mouth has tension. And then that ties into posture and neck muscles. So you start seeing them kind of when they eat, they start searching for ways to find
Mm-hmm.
stability, general tension there, so it irritates the neck. And then we start seeing a lot of times when it comes to facial pain, hypersensitivity gets triggered very quickly. Like once you've been in pain for a while,
Mm-hmm.
maybe it has to do, again, tying it back to swallowing and mouth function. Um, Now you start getting more sensitized in the area because you've been in pain. And then the more sensitized you become, the brain isn't as good at remembering the original area of the problem.
Yes.
Start getting the headaches and the pain radiating, and it kind of turns into a whole thing. So people that I see would have general tension, just uncomfortable. They kind of are headachy when they wake up, or they grind, typically if there's an airway issue involved. Um, and they just feel like it's not that specific, I just have pain here, I just have pain here. It's more of that kind of global discomfort. So this just kind of continues
Mm-hmm.
on the age spectrum as they grow.
Yes, and they have a hard time. Sometimes patients have a hard time even pinpointing like this is where the pain is coming from. In the
Right.
dental office, we have seen so many people. Let me make this so you can see it.
Yeah.
In the dental office, we have so many people that would come in and say, "Oh my gosh, my tooth is hurting. My tooth is hurting," and then the dentist would do a root canal, and then they would come back not long after that. Well, it's still hurting. It's still hurting. Nobody is looking at muscles.
Yeah.
And it is insane how
Yeah.
much muscles and fascia could be responsible for that pain because toothache is, I feel like, way more common, right, than you having jaw pain or something else going on. So there's something called referred pain
Oh
that your
yeah.
brain tells you the pain is coming from somewhere else when it's actually, it could be the muscle or something that
It
the
is.
dentist is not really looking into.
Yeah, absolutely. The muscles, a lot of the mastication muscles or the muscles that you chew with refer to the actual teeth themselves. The TMJ joint itself is innervated by a branch of the trigeminal nerve, which innervates literally your whole face. So if there is a dysfunction going on there in the joint, you could have pain anywhere. You could have sinus pain. You could have headache pain. It can refer to the top of the head. And like you said, that's why differential diagnosis, but also
Yes.
different professionals is important.
Mm-hmm.
You can't really treat this thing in a vacuum. You need a systematic approach. So I'm curious, when you go, so let's actually start a little higher level. What does myofunctional treatment actually look like? Or like, what is involved in this type of treatment?
There's two things. There's myotherapy and there's
Okay.
myofunctional therapy.
Okay.
Um, myotherapy is a list of exercises. And
Okay.
just like you go to the gym and you grab an app and you just randomly select exercises for you to do. Is it going to benefit you? Yes, it's going to benefit you in some way. However, it's not targeted.
Okay.
Myofunctional therapy usually is a person who's going to look at the patient in a way more broad view. And we're going to recommend nasal hygiene. We're going to recommend working with other professionals. We're going to be able to recognize when something is not in our field and we can't help the patient. It's not just the exercises. I have had patients that have gotten tremendous improvement from the first time that I saw them up to session 1. We hadn't even started. And all of a sudden their nasal breathing, their lips are closed because they already have the education and understanding how the tongue is supposed to live there. What are we supposed to do to clear up the nose and take care of all these allergens and things and diet that could be going on in their life that could be affecting their breathing. So myofunctional therapy is targeted and it's going to look different for everybody. They're silly exercises a lot of times. So if you guys look at my Instagram, I'm always, moving your tongue side to side. But what I'm looking for tongue mobility. The tongue needs to be able to do the functions of the tongue without engaging all these different muscles. And to go back to what you mentioned before, that we're going to compensate by using different muscles whenever we can't use what we're supposed to. We're very intelligent individuals. We're
Yeah.
always going to, we have to chew, we have to swallow, we have to breathe. These are essential functions. And if for some reason the muscle is too weak, you have a tongue tie, your upper and your lower jaw are too small, you can't breathe through your nose, you are going to engage other muscles. And that's when pain can happen because you're contracting those muscles in the wrong way too much, not how they're supposed to be used.
I think you made a great point about, I never even knew about myotherapy and myofunctional therapy, but in today's day and age, you can find any exercise, any
Yes.
strategy that people use, at least 99% of them, you can find on the internet, of course,
Yes.
especially with AI, ChatGPT, you can search anything.
Mm-hmm.
But the thing is, what is the right, number one, what is the right one for you? Because that's the
Mm-hmm.
bigger piece to the puzzle. And then, of course, understanding, outside of your specialty of, is this the right exercise? What's the progression? Who
Mm-hmm.
else do you need to see, or what other strategies do you need to use? That's the biggest piece of it. So some people, just by luck of the draw, you may, like in my world, have a certain pain, and you might be able to go on the internet and find an exercise, and you do it, and it fixes it for you because you
Mm-hmm.
only were in pain for a short period of time, and you got really lucky, and you happened to figure out the right one for you. Now, generally, if this is a more systemic, ongoing issue,
Mm-hmm.
number one, it's gonna be so much more complicated than a couple exercises. And then just the pure likelihood that you were able to figure that out on your own is so low. There ends up becoming a lot of time and money that becomes wasted, or it's a lot of time that becomes wasted just trying to figure this out on your own. And so it's
Mm-hmm.
two totally different things. I had someone who, it was my first bad review in like 5, 6 years, um, and they said that the exercises that I gave them, I looked on the internet and I could have found them on the internet. And I was trying to explain, every single exercise is on the internet. Were relying on me to identify the ones that were going to solve your problem the quickest and help the most. And it just so
Mm-hmm.
happens for you, they were a couple of the ones that you could have found on the internet. And so there's two different types of therapy, and it just depends how deep you have to go into it.
Mm-hmm. As an example, there are tons of dentists out there that will send me patients to have tongue tie releases. And
Hmm.
I'm like, okay, where's the sleep study? Oh, we didn't do one. Where's the CBCT X-ray? It's a 3D X-ray that goes all the way around you. Oh, we don't have one. You
Mm-hmm.
know, and
Yeah, yeah.
I have had some patients that are extremely overweight,
Mm-hmm.
extremely overweight. They have sleep apnea and they want to release their tongue thinking it's going to fix.
Right.
Sleep apnea is a different ball game. That
Mm-hmm.
is a very complex disorder. And
Mm-hmm.
weight loss is, you know, it's part of it. I
Right.
think it's irresponsible for somebody to release somebody's tongue without addressing their weight first.
So using that to segue into the next piece of it. So we kind of talked about how people present when they have different types of myofunctional and airway-based issues. We talked about the different types of therapies that you could potentially receive. What are, when you're actually looking at dysfunctions, what are the ones that you find are at the top of the list? So like everything from like you said, maybe obesity, maybe like an obstructive airway issue, maybe a frenulum, or maybe a cheek tie, or is it more about the motor movement? Are there ones that seem to be more prevalent issues, or like what are the things you're actually finding in there that are more common?
Number one, nasal obstruction.
Okay.
100%. And they all go hand in hand. Why do we have more nasal obstruction now? Because one, we don't live in caves anymore. We don't have clear air. You
Mm-hmm.
know, so we are way exposed to more allergens and to houses with, you know, all this dust and all these things going on. Pets living with us inside the
Yep.
home. Number two, diet. Diet is going to affect and can cause inflammation, especially dairy. I usually recommend no dairy. Dairy is inflammatory, and then gluten, processed foods, and sugar. If you're trying to like reduce tonsils and adenoids, you have to
Inflammation.
look at inflammation in the body. Um, so what else can affect nasal obstruction? Lack of using the nose. If you got sick for like a month and you started not using the nose anymore, all of a sudden it's going to become harder. There's something called nasal disuse, that the more you not use your nose, the more your
Mm,
nose is not going to work.
mm,
So that's something that myofunctional therapy really can help, teaching you how to use your nose again. Tons of nasal hygiene. We do some breathing exercises, but I think that top of the list right now is definitely nasal obstruction, and it's going to be a cascade affecting all of the other issues. So
mhm.
let's say that you have a tongue tie. So if you have a tongue tie, your tongue cannot be placed where it's supposed to live all day long, which is the roof of your mouth. Your tongue is supposed to be lightly suctioned up there.
Mhm.
If you have a tongue tie and you cannot keep your tongue up there, guess what's going to happen? You're going to breathe through your mouth.
Right.
Even if maybe you don't have nasal obstruction, then you get used to it, then you need us.
Mhm.
Let's say that your upper and your lower jaw did not grow to its full potential. So you have crooked teeth. Kids do not have any spaces in between their teeth. They're supposed to have spaces, little kids.
Mhm.
Then your tongue can fit up there. Guess what's going to happen? Your tongue is going to live down here and you're going to mouth breathe.
Yeah.
So a lot of it is nasal obstruction, but it could also, I mean, the jaws affect the nose, the tongue affects the nose, and vice versa.
Yeah. Yeah. That's interesting. So really understanding that nasal obstruction. And so how often, what percentage of people would you say actually end up needing some type of, or children, some type of releases? Is it just if they have feeding issues? Like they it's, or what would you say?
I like to be very conservative when it comes to recommending a tongue tie release. I'm actually not a huge fan of buccal ties at all. There's just not a lot of research. Actually, the only research that's out there is by Dr. Baxter, who's incredible. But we need more research. So I try to stay away from that. I let the release provider really have full responsibility on that one. Um, and then upper lip
Mhm.
and lower lip. This one also I barely ever recommend. Only if it's starting
The
to pull the gums down,
the
the
lower
lower,
lip you barely
yeah, the
recommend.
mandibular or
Yep.
the lower lip tie. Only if it's like pulling the tissue around the teeth, so the gums down. The upper lip is very common, and some people say that if you have a lip tie, 99% of the time you have a tongue tie. So always check both. The lip is more obvious, easier to see if it's keeping the both upper teeth apart.
Mhm.
Usually kids will have a little bit of harder time closing their lips because it looks like the upper lip is short or it's rolled up a little bit, and it could be the lip tie. So always check that first.
And also when with feeding, then they're not going to be able to actually pull outward, right? Isn't that? Well, that's what I've heard.
Yes,
That's what I've.
I know a lot of people say that you're supposed to have the upper lip flared out on the bottle or on the breast. I have had conflicting informations about that with IBCLC, so I'm not a specialist in feeding, but I have had some SLPs, not speech pathologists, but
Yeah.
IBCLCs tell me that still don't know what's going on inside, that they don't necessarily have to have the upper lip flared out for them to be able to functionally feed. So I am not sure, but everybody wants to have that. But I'm not really convinced. So yes, usually lip tie and tongue tie is what we see the most. How often do I recommend getting a release when it's impacting their function? So not only feeding, I'm looking at lateralization. Can you move your tongue side to side? You guys can try this with me. Open wide as you can, and move your tongue, the tip of your tongue to the corner of your mouth, and then to the other corner. Are you able to do that easily without moving your jaw? If you saw your jaw move, that means you're compensating. But guess what? If you do that throughout your life, what's right above your lower jaw right here? It's your TMJ. But we're just talking about the TMJ. If every single time you're supposed to move your tongue by itself, and you can't because either you tongue tie or you have low tone, you're using your jaw to do those movements, you're going to end up having TMJ symptoms because you're wrongly using that joint.
Right. You're trying to move the jaw around the tongue versus the tongue around the jaw.
I like to explain, like, think about if you're stepping the wrong way all day long, eventually after so many years, you're going to need knee replacement surgery. The joint is the same thing. If you're not using your jaw correctly, you are going to have issues later in life.
Yeah, having that mobility is important. We see that a lot with like the knee joint as well. If someone has knee pain, sometimes it's not that the kneecap is moving incorrectly on the knee or on the bone, like on the femur bone. It's that the femur bone starts moving underneath the patella. So is it like the chicken or the egg? So it's the same kind of thing. If you can't actually move the tongue all the way around, but you know you need to shift your jaw, then you're going to overuse the jaw to achieve that.
Another cool thing to check whenever you're looking at yourself in a mirror or your child, notice if whenever they're walking, their lower jaw constantly comes forward. Whenever you ask a child to smile for a photo, see if they bring their teeth together to smile, like that fake smile, instead of biting down and smiling. That is telling me that the joint is more comfortable in that position. So usually the upper jaw is too far back in those cases. And the lower jaw is trying to go to its position, which is supposed to be more forward. But either the maxilla is trapping that down, or they have a tongue tie and no myofunctional therapy that keeps the tongue stays back and low.
Yeah. You know, I find a lot of times when it comes to the actual positioning of the neck and jaw as well, we can actually, as your head, the more forward that your head is, the more that the inferent suprahyoid muscles that connect all to the jaw, they start pulling it back. So you can actually have a retruded jaw as you're in that forward position. And I see a lot of people who either have clicks in the jaw, in the TMJ, or they have an irritation or discomfort. If I had them functionally move in provoked bad posture versus an improved positioning, then the click can reduce and the discomfort as well. And so it's just, again, bring it back to that term functional. It's how are you moving? And I also find things like a restricted shoulder joint on one side. What happens is if your shoulder can't freely move up, you get to a certain point, you start shrugging. And now you start shrugging, you start irritating this side. Now you have a little bit of a tilt in your jaw as throughout the day as you move, or a tilt in the head position. And then you start making uneven condyle or really tooth contact. And then this can kind of trickle into a whole downstream effect.
I have a question for anybody listening. Can you guys post in the comments, have you ever had braces? Number one. And number two, have you had any teeth extracted? This is something that we hear all the time. And whenever I say teeth extracted, not baby teeth, usually orthodontists will recommend certain patients to take out 2 premolar teeth. They are 2 on the top, 2 on the bottom. I have so many patients that had no issues, and all of a sudden they start with clicking, popping, pain. After having orthodontics, which sometimes, yes, it's retruded, it kind of holds everything back. The wisdom teeth also won't count. But if you had premolar extraction. Did
Right.
you, because people don't put two and two together. I'm talking to a patient and they're telling, I have facial pain, I have clicking, I have popping, I've had these issues forever. And they'll say, well, when did this start? Oh, it was around high school. I was like, okay, what year
Hmm.
did you finish your orthodontics? And it's always around the same time. So
Yeah.
take a look at that, ask yourself those questions, because a lot of traditional orthodontics, unfortunately, they are taught to look at the teeth and to make sure that the teeth will
They
fit.
look.
But
Yeah.
they're not looking for the space major migraines after twin blocks and braces, extractions later for wisdom teeth. Yeah, there's so many. I have patients who had the Herbst appliance, and I mean, they're adults now, and to this day, they're trying to find answers. They have so much pain.
Yeah.
So we want to increase the size of the jaw to be able to house all of your teeth and to house the tongue. That's why there's no reason to waiting. We need to start treating these kids early.
Yeah. I can't tell you how many people who just started brace orthodontic treatment who now have pain, and then they come in to see me, and it comes down to, should we pause the treatments? I usually recommend like to pause it if the orthodontist is okay with it. Let's just pause that, because I don't want to be introducing multiple factors at a time. Let's just keep you where you're at and see what we can do with it. Can we make improvements here? Can we not make improvements? And then you can go on. But if you start moving the teeth at the same time you're trying to realign the jaw and improve the neck jaw synergy,
They're
you're going
fighting
to
each
have,
other.
yeah, you're fighting each other. And yes, I have been hearing that more about, generally, for the most part, orthodontics and braces are more of a, what's the word I'm looking for? It's just for how
Aesthetics.
aesthetics. Yeah, it's for aesthetics. So it is really interesting, and you never questioned it. I mean, I had braces growing up, I never thought about it, but now I'm thinking about it. It's like you're taking the foundation of your mouth and you're just cramming things into a different position so that your teeth look good. But what does that say for the function?
However,
Yeah.
it's teeth aesthetics.
Yeah,
If you
yeah.
look at the person's face, it looks
Oh, the
worse.
facial structure.
They are not looking at the face. I just had one of my students sent me a photo of a local patient. She goes, the orthodontics is done with her. And
Hmm.
she sent me a side profile, and the jaw is totally too far back. How can you be
Mm.
done? All the teeth,
Yeah.
they're in class one, they look great. There's so much dysfunction that is going to start happening there. Somebody just said, had braces for 3 years
Yeah.
and a half due to underbite. Toward the end, I started getting pain on my jaw, joint, neck,
Yeah.
and migraines. It's so sad.
It is interesting, even with and I don't want to, I don't know enough about it, about the subtleties of it, but just the concept of adding rubber. If the goal is, and in order to achieve that aesthetics, you're going to add rubber bands to change the position, and it's not have anything to do with function. It is kind of crazy when you think about it. It's one of those things
Yes.
that's just not questioned over time.
So,
Yeah. Go ahead.
someone mentioned hypermobility a couple of times here,
Yeah.
and some other appliances. I'm not a huge fan of functional appliances. Most of these functional appliances only move teeth. I am of the thought that you need to increase the size of the bone that holds the teeth. You can only do that with a couple different ways. The one is the one that I did. I had the MARPI done, which is a device that goes in the roof of the mouth and you turn with like a wrench. So it
Yeah.
literally,
It's
if you
just
guys
it
look,
open. Yeah.
if you guys look at my photos, I have it in my highlights under MARPI. I had crooked teeth everywhere, but my cheekbones are higher. My nose is wider. I can breathe so much better. So I am of the thought,
After using that device.
yes, I am of the thought that you need to look for the root cause. The root cause was my maxilla was too small. I can move the teeth within the bone and make it look like it's wider and get the tongue to live up there. However, I'm not changing the skeletal structure. I did not want to go into surgery. My father has sleep apnea. I wanted to prevent that. There's a big correlation of the size, the width of your jaw, and sleep apnea. So I knew I was already, as soon as I hit menopause, it's going to happen. So I try to avoid that. However, if you're hypermobile, you have to be careful. Any little movement that you do to a hypermobile patient, first of all, you have to be working with a body professional, somebody who's experienced with it. But I have seen some hypermobile patients have treatment done and just go downhill,
So are
especially of
you
the severity.
so as an adult, you use that expander, you're saying?
I did. You guys have to see my before and
Did,
after. It's
did
crazy. It
you,
looks so different.
so you only expanded the maxilla?
So
So
you
the
can expand
mandible,
a mandible.
so there doesn't, so after that expansion, do they have to take that into consideration if now you were going to be too wide on the top?
So the way that it happens, if you look, most people's teeth, if you have them smile like
Yeah.
this on the side, you're going to notice that the lower teeth are inclined towards the tongue. So usually what my
Okay.
orthodontist does.
Yes, yeah, they pull them all inward.
So what my orthodontist did, he decided to do, which is Dr. Ilya Lipkin, love him. He's incredible. He's in New Jersey. And I flew from Savannah to see him because he is the best in the world. He's worth it. But the lower teeth are inclined towards the tongue. So he put Invisalign on the bottom and moved my teeth within the bone, just like regular orthodontics. However, he pulled them up. He uprighted them. So the second that you upright the lower teeth, then you're almost in a crossbite on the top. So you have plenty of room to expand the top.
So once you take those teeth that are in, though, and you open them, there's going to be spaces between the upper portions of them.
Not necessarily.
Because they would be naturally tipped in to hit here. So
Yes.
So wouldn't he have to pull it up and then forward too? I'm just.
Yeah, they move them a little bit, but no, usually there was no movement forward that I needed. And most people have lower anterior crowding, so you have crowding on the lower teeth. So usually whenever they start uprighting the teeth and, doing ortho, they can fix that. But that is definitely not a concern that anybody should have. There are other more aggressive procedures for people who have a very small jaw and a lower jaw.
Yeah.
Well, retreated is a little bit different. Usually retreated, it's usually surgery. But
that's what I thought you were referring to.
No, there's something else that's called SFOT. Where they open all of the gums on the bottom, they pack bone, and all of a sudden you have enough room to move your teeth way farther out. One of my therapists, Emily, just had this done. She has her whole journey also recorded here on Instagram. But she's going through double jaw surgery. She had the MARPI, she did the SFOT, and now she's eventually doing, when she's ready, double jaw surgery.
Okay.
It's a lot.
So basically, though, what you've found is that non-surgical, the only way to actually expand the maxilla is with some type of
with a MARPI,
basically, to actually shift it outwards. But how much? Because I could go all day about this, but we haven't really talked about Airway, but if someone's having trouble getting their tongue up to the roof of the mouth and keeping it there because of restriction, and what I've been told is that from Dr. Scott Siegel, I love him. So he says that it's either a restriction or not a restriction. There's no tongue. It's not an in-between tongue tie. You're either tied or you're not. If you have that restriction there and you're not going to release it, how much more play can you get with myofunctional to actually get up to the tongue? Keep it up to the roof?
That's a great question. First, there's several severities of tongue restriction. You can be very restricted. That's a grade 4 under the TRMR scale. That's the one that usually we like to use nowadays. So there's a classification system now for severity of tongue tie. Grade 4 means your tongue cannot even lift from the floor of your mouth, barely. A grade 3, you can lift a little bit. Grade 2, you can lift almost 80% up. And then a grade 1, you can lift and touch. You can open your mouth wide and still touch the tip of your tongue up there. However, there are compensations. So you may look like you have great mobility, but if the floor of your mouth is going up, for example, then it's a compensation. And there's a way that we can check to see if you're still tied by holding the floor of the mouth down and trying to elevate the tongue. So even though you either have a tie or you not have a tie, there's still some people are way worse than others. True. When it comes to myofunctional therapy, to try to optimize the function of the tongue when there's still a tongue restriction, it's important for us to understand the anatomy and what it looks like underneath the tongue. So there are little tiny muscle fibers underneath the tongue, and the tongue is muscle, right? So with myofunctional therapy, we can optimize the movement of the tongue. We can increase tone, increase strength, make sure that the movements are way more coordinated and organized. However, that little string underneath your tongue cannot be stretched. If you have a restriction there, you're always going to have a restriction. I have the book Tongue Tied right there that I translated to Portuguese by Dr. Baxter. So you cannot stretch that tongue.
Right.
However,
If it's a tie.
exactly. If somebody can breathe well through their nose, can keep their lips closed, can sleep with their mouth closed, they're chewing fine on both sides. They are able to move the food around, swallow without any negative compensations, meaning pursing your lips. Watch whenever you take a sip of water right now. Take a sip of water, put the cup down, and look at yourself in the mirror. Do you see any movement on your lips or your cheeks? You're not supposed to have any of that. The tongue is supposed to do everything by itself. Um, so we are going to look at all those compensations. If we're able to get to a place where the person can function without those negative compensations, then there's no reason to release the tie.
Right. Okay. Fair enough. I guess I got one more question for you. When it comes to any type of sleep breathing disorder, if we're seeing not necessarily sleep apnea or obstructive sleep apnea, but some type of airway issue, um, or if their airway even collapses during sleep, they snore. That's another good one. Has there been anything that you've found to be able to do within the mouth to address that pure function of the airway small and it collapses? Besides for maybe, like you said, weight loss and inflammation, or is that a different situation that is harder to manage?
So specifically about snoring first.
Yeah.
First, we have to find out where is the snoring coming from. Is it the nose? Is it the tongue and the soft palate? So you're going to have to address whatever it is. For all of my patients, I need to make sure that they are able to breathe through their nose. So I usually say that there's 3 pillars to treatment. The first one is the airway. So this tube that goes from the nose all the way to your lungs needs to be free and clear. That's why many times I need an ENT to make sure there's no enlarged tonsils or adenoids or a deviated septum or nasal polyps or allergies need to be treated so the turbinates are not swollen. So we have to look at that first. If they can breathe perfectly through the nose, but they are snoring, but it's coming from over here. A lot of times their soft palate is too low. So whenever you open up and you see that dangling thing all the way in the back of your mouth, it's called your uvula. If that is too low and your tongue is positioned low and back, a lot of times because of a tongue tie, those 2 structures can collapse whenever you are asleep. So we have to address them. How do we address those 2 structures? One, myofunctional therapy to get the tongue positioned correctly and maybe a release done. And for the soft palate, we do actually myofunctional therapy exercises to tone up those muscles. And with women, it's actually interesting because they don't usually start snoring or having sleep apnea symptoms until they hit menopause. Because whenever we lose our hormones, our muscles sag, and it happens in the roof of the mouth also. But then there's another thing that we have to look at. A lot of times when people have this low soft palate, it's because their upper jaw is too narrow. And whenever you do what I did and you expand the roof of the mouth, all of a sudden the soft palate raises a little bit.
Right.
So
I love it.
I'll relate it.
Yeah. Is there anything else that you wanted to touch on?
Oh my goodness. I can stay here all day and I can talk if you guys can see. Somebody's asking for nightlays for airway management. I think that that's a great extra tool to be used.
Gotcha. Yeah, I mean, I think that we covered so much here. You were very articulate and you know how to go into things. So I feel like we were able to kind of pull out a ton of information. But I agree with you on it's never a simple, here's your sheet of stuff to do. There's a lot of testing. We're going to try this. We're going to see if it helps. It might not help at all. It might help. It's our best. It's our hypothesis right now.
Yes.
We have to test it to get the answers to get to the next step. And I think the people who get better are the people who are saying like, okay, like I'm ready to go for a ride on this journey and I'm going to stick with through the journey. And you have to understand that there's going to be efforts that you put in that don't pay off. And then that's how you learn to get the next step. And that's why starting conservative, because that's a fact. We already know that that's a fact. right? Unless you, again, going back to what I said earlier, unless you get lucky, it's going to take some trial and error. And that's why you should always be starting with the conservative stuff first, because this is where you can really play and get in there and understand relationships and dynamics. And if you're willing to kind of go on that journey with someone who knows what they're doing, you can have excellent results. And I feel like that's kind of what we've been able to cover here.
I think it's important for people to realize if they're going to go, if they are having pain or if they are in the airway journey, like you said, it is a journey. It is not one
Yeah.
thing that's going to fix everything. And it's so easy out there for us to hear somebody saying, oh, you have that pain. Oh, it's gut health. Oh, you have that pain. Or it's because you had your teeth extracted.
Yeah.
Oh,
Yeah.
you're having that
Right.
pain. Oh, you just need a massage. Everybody is going to have the answer for you. And the truth
Right.
is that everybody is individualized and you're
Yeah.
complex, and not every treatment is for you. So working with a team that you actually trust,
Yeah.
that you can talk to, and they are also working with other professionals. They're okay working with other professionals.
Yeah.
It's
Yeah. That's true too.
usually, yes, I've had, just this morning, I had somebody say, somebody that I referred to an orthodontist, and they told my patient, oh, don't do myofunctional therapy. I can give you some exercises, and they did,
Right. Right.
and they told me the
Yeah. You
exercises
can't
they're
be
giving
threatened.
them.
Yeah.
And
You
it's
can't.
like, oh,
Yeah. You can't be. That's another thing I fully agree with, and I tell people all the time. Like, someone else one time got mad at me because I said, we're going to try this, and then if this doesn't work, we're going to go for this or this. And after they were like, well, I don't want you to just be like playing games. I just want you to tell me what to do. I'm like, if you go to see anyone and they tell you this is what you're going to do and it's going to fix it, run. Don't go back to that
yes,
office and run, because there's no way that they can have that
you
confidence to
can't
understand,
tell.
because the body's too dynamic.
A hundred
Um,
percent.
Renata, this was amazing. I want to do this again sometime. Maybe we'll dive into like a specific topic, but thank you for
Okay.
joining me and just kind of sharing everything
Thank
all your
you.
experience.
Thank you for having me. And if
Yeah.
anybody wants to write down in the comments what do you guys want to hear next time, if you want something, very specific that we can discuss, would love that.
Yeah, absolutely. Comment on this is going to post, so you can find the post, you can comment, and we'll go through all of them.
Awesome.
Okay. All
Thank you
right.
so
Thanks everybody
much.
for joining. Thanks, Renata.
Bye bye. Thank you.
Bye.